Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. So, Alhamdulillahi Rabbil Alameen, As-salatu was-salamu ala ashrafil anbiya'i wal mursaleen wa ala alihi wa ashabihi ajmain. So the attendance is very less, it's only 57. Anyway, I'm just recording it. Inshallah, if somebody can't attend, they can listen to my lecture, but it's better to attend it. I'll go a little slower. If there are any doubts, you can ask me. This is not an easy chapter. Bronchial asthma, if only clinical features, it will be very easy. If only treatment, it will be easy. But we are going to read pathophysiology and some sort of pathogenesis should be understood. Okay. So you can keep your mics closed. If you want to ask me any question, you can ask me. Okay.
Okay.
So, yeah, actually what's happening is we are going to deal the lung diseases into restrictive lung diseases and obstructive lung diseases. Okay. I don't know, Dr. Ahmad Al-Badi has taken the class for you or not. Maybe tomorrow, I don't know.
Yes, tomorrow, Dr. Inshallah.
Yeah. Tomorrow, huh?
Yes.
Okay.
Yes.
So we have chronic obstructive pulmonary disease. Listen carefully. One of the most important Sakar al mic, Allah khalik, everybody. Close the yeah, leader, tell them to close the mics. Microphone should be closed. If you want to talk, open the mic and talk. That's all. Okay. We have chronic obstructive lung disease or chronic obstructive pulmonary disease, one of the commonest diseases in the hospital. So you got to be very careful what we are reading. So an obstructive lung disease, chronic bronchitis, emphysema, and bronchiectasis, all together they call it COPD. It will be taken up by Dr. Ahmad Al-Badi. I am going to take asthma today. Okay. Asthma. So inshallah, what is asthma? I'll tell you. Restrictive lung disease also I'll take maybe on 13th of February. That will be on the remaining lung disorders. Okay. If you have any doubt, ask me, please. Now, what is the definition of asthma? It's a chronic disease. It's a chronic disease, remember. And there's inflammation of the respiratory tract or respiratory system characterized by the bronchial hyperresponsiveness. The hassasiyya the bronchial walls, okay? Hyperresponsiveness. It is episodic, going and coming. We call it asthma attacks, okay? It is episodic exacerbations. Yani waxing and waning, zekida, okay? And it's a reversible disease. Remember, this question we asked last year in the MCQ, and many people did not do it well. So I changed whole of my what do you call it? The PowerPoint. It's a reversible airflow obstruction. I told you, chronic obstructive pulmonary disease is composed of 4 things, right? One is asthma, one is chronic bronchitis, one is emphysema, and one is bronchiectasis. Okay, now these 3 things will be taken together in the name of COPD by Dr. Ahmad Badi. I'm taking asthma. Okay, now this is the definition of asthma. What do you mean by exacerbation? Acute asthma exacerbation. It's a reversible worsening of the clinical features of asthma. Inshallah, I'll tell you the clinical features that develops over a very short period of time. Al-waqt galil yani, and can be progressed to life-threatening asthma, life-threatening. It can even take your life because the obstruction becomes very bad. And maybe the first manifestation of asthma in some patient. Maybe this is the first time they might be getting. It is acute asthma exacerbation. I request everybody to close your microphones, please. Okay. Now, ma mana allergic asthma, ma mana al-asthma al-hassasiyya. The most common type of asthma, begins with intermittent symptoms in childhood and usually associated with atopy. Atopy is again an allergic condition consists of eczema and rhinitis. It runs in families. Okay? And a very good response to treatment. The treatment does wonders. That's all. Okay? And the last thing in definition is non-allergic asthma, and asthma ghair hassasiyya, an uncommon type of asthma that is not related to atopy, not related to family history, and is typically associated with poor response. The treatment is poor response to standard therapy. Okay. Now, if you have any doubt in this asthma definitions, ask me now. Okay, the ARBA definition. This is the common definition of asthma. This is acute asthma exacerbation in a very short period of time. Third is asthma al-hasasiyya, and fourth is asthma غير حساسية. لازم يعرفون أنت موجود عندك الباوربوينت، إذا كان أنت تقرأ مرة أخرى إن شاء الله يستفيد وتفهم الشيء. Okay. Now you can see the trachea. It is divided into the segmental bronchus, then the subsegmental bronchus, then the bronchiole. Okay. And this is the terminal bronchiole, in the bronchiole, the respiratory bronchiole, and the alveoli. Inshallah, okay, I will try to teach you what actually happens in terminal bronchiole, what actually happens in respiratory bronchiole, what is the main pathology of alveoli. Accordingly, we'll try to go. Okay. Now you see asthma. Again, I tell you, last year's question, it's a reversible bronchoconstriction, usually due to allergic stimulus. Maybe one zai hasasiya, mumkin fir air, wala pollen, and this type of hasasiya is type 1 hypersensitivity. Type 1 hypersensitivity. Remember, okay? Reaction. All the airways, especially these airways like terminal bronchiole, respiratory bronchiole, these type of airways are hyper-responsive. Hyper-responsive are again allergic concept, okay? And asthma is very common in atfal. Very common in atfal. And they're associated, most of the asthma associated allergic hasasiyah, atopic conditions running in family history. And I just told you it is the family history means eczema. What do you mean by atopic? Eczema, along with this asthma, eczema, plus rhinitis. Okay? Like rhinitis and eczema, and may have a family history of allergic reaction. So this is the basic details of asthma, which is a very common disease in the hospital, not only in children, but also in adults. You can go to Malik Fahad or you can go to Vilada. You will be able to see such diseases. Okay. Now, we'll try to understand ma farq bain asthma al-hasasiyya wal asthma al-ghair hasasiyya, non-allergic or allergic. Okay. Now, cardinal risk factor in allergic, as I told you, is an atopy. Runs in families. We'll have eczema of the skin. Plus, it will have rhinitis. And this patient will have asthma. Okay. Now, environmental allergens like pollen, seasonal, okay, like maybe in the spring season, or the dust mites, or the domestic animals. Sometimes you have cats at house, or some pets at home. Okay, some people have dogs, and sometimes the mold spores. And this question comes in SMLE. The people who want to get good marks, try to read these notes. Very, very important. Okay, allergic occupational asthma, and maybe I had wazifa in hunak al-hasasiyya ziyada, exposure to allergens in the workplace like floor dust. If somebody is working in a floor dust, okay, that floor will allergy. Okay, I request you to everybody to close the mic.
Doctor, can you give me access?
Huh?
So I can you give me the access so I can mute anyone?
Okay, sure. Your name here, Muhammad Sana.
Yes, Mohammed Sansa, yeah.
But I can use the PowerPoint, right? Mumkin wala?
Yes, you can use.
Okay, Sana, Muhammad Sana. Okay, you are the host now.
Okay.
Yes. But that is gone. My PowerPoint is gone.
You can share it again.
Well, the host disabled the screen sharing. You have to share with me.
Okay.
You close the mic. Somebody has opened the mics, I think so. Host disabled participant screen sharing. Okay, right. No problem. Okay. Is it okay? Can you see the screen now? Sanaf?
Yes.
Yeah, okay, right. No, so you got to understand this asthma triggers. The allergic asthma hasasiyya. Very easy. Now, when you go to ghair hasasiyya asthma, hada yusamma intrinsic asthma. Hada yusamma allergic extrinsic asthma. Intrinsic asthma like very, very important again, important for the examination point of view. Viral respiratory tract infections, one of the most common stimuli, especially children. Any viral infections which occur in the children will cause asthma. This will be the causes, okay, triggers. I had cold air also, cold air, okay. Hawa al-bard yani. Physical examination like laughter, exercise-induced asthma. We have seen in the gyms, some people when they go to the gym, they get asthma because of a physical exertion. Some people when they have a gastroesophageal reflux disease, often exists concurrently. It is a triggering factor for asthma. And some people with chronic sinusitis and rhinitis. And some people, they're using Panadol, aspirin, non-steroidal anti-inflammatory drugs, beta blockers, al-muhim jiddan al-aspirin. Aspirin, very famous. This will come in the as an MCQ, remember. Okay. And some in the stress-induced. So irritant-induced asthma also. From exposure to solvents like ozone, tobacco. Tobacco, people smoke a lot. This can also cause a asthma, or some wood. Khashab yani. Regida, smoke and cleansing agents and isocyanates. These are all the asthma ghair hassasiyya. Okay, very, very important to understand. So I hope you understand these things and you understand this particular diagram where the terminal bronchial, these areas are actually involved in the asthma. Okay, we go furthermore. Okay, now the etiology, yani asbab. Okay, the cause of asthma. The exact etiology of asthma remains unknown. In many patients, we don't know what causes asthma. But risk factors for asthma, now this will come in the exam as MCQs, remember, okay? Family history, past history of hassasiyya, atopic dermatitis, with the people will have eczema plus rhinitis. You can see running in the family history, okay, like this. And the low socioeconomic status, like when you go to for countries like India and go to China, or the people in the African countries where there's low socioeconomic status, also you can find asthma. Hada kullu etiology, but many patients have exact etiology remains unknown. Yani yusamma ish idiopathic. Okay, right. See also risk factors for fatal asthma exacerbations will also cause the etiology. Several factors can triggering. I just give you the asthma triggers. This is very important slide. Asthma triggers, which I gave you. Okay, now this triggers you got to remember for your examination as well in the hospital coming year or after 2 years. Now, several factors can trigger an initial asthma attack or cause acute asthma exacerbation or an asthma attack. You remember on the first page, these are definitions. Number 1, number 2, number 3, number 4. The definition of asthma, definition of acute asthma exacerbation. Okay, it's a life-threatening event. Number 3, asthma hassasiyya. Number 4, asthma ghair hassasiyya. Okay, we go furthermore now. What are the clinical features? What are the signs and symptoms of asthma? Okay, the following features are usually intermittent and coming and going, coming and going, coming and going, and can occur either sporadically or in response to any asthma trigger which can cause hassasiyya or ghair hassasiyya. Asthma triggers, I just go back, hada kullu asthma triggers. Shuf, hada asthma triggers. This page is very, very important for you to understand. Okay, now I go over here. What are the typical features? Number 1, persistent dry cough. Now, dry cough for many people, it causes a lot of problem. You go to Wahda Tibbiya, take the expectorants, take the cough syrup, Mafi Faida, okay, like that. It worsens at night. At night, it worsens. With exercise, it worsens. On exposure to any allergen or triggers, irritant like cold air, hawa al-barid, any allergen or smoke, it worsens. It worsens. Or it triggers. Okay, triggers. Kullu, persistent dry cough, number 1. Number 2, end expiratory wheezes. When you do the expiration, we do inspiration and inhaling air inside Usama inspiration. Exhaling air outside
Expiration.
expiration. So at the end of expiration, you have a wheeze. Wheeze, I'll make a sound. I think you can understand. Zay kida. أفهمتم؟ هذا
Can
يسمى
you repeat it?
Okay, can you hear me? هذا يسمى
Yes, we can.
Yeah, هذا يسمى wheezing, like a whistle, like a whistle. You can see many people just sit beside them, they are like whistling. Okay, like that. إذا كان في زي موية خلول هذا يسمى crepitation. That occurs in pneumonia or that can occur in chronic bronchitis, but in wheezing occurs in asthma. I wanted to show myself and I can show you, but inshallah, nothing, don't worry. Now the third is dyspnea. Dyspnea and a shortness of breath and a breathlessness. Okay. Number 4, chest tightness. The people will be apprehensive. Sure. Apprehensive. Apprehensive. Apprehensive yani zay khauf. They'll come with chest tightness. Zay khauf yani. Okay. With chest tightness. Okay. Rakam 5, prolonged expiratory phase or auscultation. When you put the stethoscope, you can see the expiratory phase ziyada. Like this. Inspiration is small, but expiration is long. Okay. Then comes Rakam 6, hyperresonance on lung percussion. It is a kind of the survey lung percussion with the hand like that. You get something like you beating a tabla, dum, 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 like something air inside. You know the tabla in India they put the tabla in the music like tabla, tum tum tum, like as you beating something a drum inside the drum there is an air. Zaykida, as I use some hyper resonance. So I think you understand the clinic features. I made the PowerPoint very simple for you to understand. Okay, we go further. Now this is the main chapter for us. We got to understand this, and this is our main chapter. We got to know what is happening actually in this particular area. So when you go into the details of this one, what we are able to understand, as I'll tell you, try to tell you, asthma is an inflammatory disease, right? I told you it's a chronic inflammatory disease and sometimes with an acute exacerbation. Now these are driven by not T helper 1, but they are driven by T helper 2 cells. They are T cell mediated, but helper 2 cells that manifest in individuals with some genetic predisposition. Now, this is very important definition. Understanding the pathophysiology. It consists of the following 3 pathophysiological processes. You got to know. Number 1 is bronchial hyperresponsiveness. I told you before. Bronchial inflammation. Okay. And the third is endobronchial obstruction. Now, you got to remember this. Now, if you remember these 3, هذا كفاية جدا لتفهم الباثوفيزيولوجي. أول كان البronchial hyperresponsiveness. You got to know this. Okay, I'll show you very good diagrams, then you can understand. Now, number careful, mana hyperresponsiveness. I'll try to show you in the diagram. Number 2, bronchial inflammation and symptoms caused by inflammation of the terminal bronchioles. Okay, I'll go back. Shuf hada terminal bronchiole. Shuf hina hada area. This area, remember, this will come in the exam. This will become hyper responsive. Okay, and this area will be affected allergically. Okay, and this area will have more mediators. Okay, more problems with obstruction. Afahemtum? Okay, now we go furthermore. Now, symptoms are primarily caused by inflammation of the terminal bronchiole. Shuf, again, I just go back because you should not forget. It is not the pathology of respiratory bronchioles, not the pathology of alveoli, not the pathology of segmental bronchus, not the pathology of the trachea, but it is the pathology of terminal bronchioles. Lazim, yarif lazim yani tahfaz al-shay, tahfaz. Okay. Okay, now we go furthermore. So it's inflammation caused by inflammation of the terminal bronchioles, which are lined by smooth muscles. Inshallah, I will show you, but lack the cartilage. Has a muhim jiddan fil imtihan. Cartilage found in the larger airways. So they lack cartilage. Okay, I'll go back. Till here, shuf, till here. Cartilage mawjood. Cartilage mawjood. After that, the cartilage will go off. Understand? Okay. Now the cartilage, but lack the cartilage. Also, overexpression of the Th2 cells Inhalation of antigen results in production of, these are the cytokines which will be the mediators of inflammation in the terminal bronchus. Remember, interleukin 3, interleukin 4, interleukin 5, interleukin 13, that activates the activation of eosinophils, which causes hassasiyah, and induction of the cellular response, that is the B cell, that is the IgE mediated. Remember, this is very, very important to tell you. Okay. Then the bronchial submucosal edema, I show you the diagram, and the smooth muscle contraction. All the bronchioles, so far the bronchioles will collapse. If they can collapse, just imagine, will there be airflow easy or difficult? It will be difficult. So there will be obstruction. Okay, remember that one. Very important. Inshallah, I'll go into details after seeing the diagram, you will understand. Now, the number 1 was bronchial hyperresponsiveness. Number 2, the bronchial inflammation. Number 3, endobronchial obstruction, which causes the parasympathetic tone to increase. Not the sympathetic. Sympathetic will open, parasympathetic will close the airways. So there is a reversible bronchospasm. There's a lot of mucus production. Okay. I don't know what you call in Arabic. It's the zay balgam yani, balgam. Okay. You have a lot of watery balgam coming out. But usually we have, when we call balgam, we think it is iltihab yani. But it is mucus basically. And balgam bidun al iltihab, yusamma mucus. Faham kef? Mucosal edema and leukocytic infiltration. Come on, Phil, WBCs, Juba like Zekida, lymphocytes, plasma cells, neutrophils, into the mucosa, and hyperplasia of the goblets. And inshallah, you see the diagram. Akhir shay, increase parasympathetic tone. Number 2, hypertrophy of the smooth muscles. Inshallah, we will see in the diagram. See in the diagram. I'll draw the diagram. I think it's already drawn. I'll show you. Now this particular thing is very important for your examination. Number 1, number 2. Now, this is a summary. Basically, it's a summary. Now, allergens. Okay, the substances will cause hassasiyah induced, I told you, T helper 2 phenotype, that is CD4 T plus cells, genetically susceptible individuals are the kullu muraja. I already told you. So muraja. Okay. Now, T helper 2 cells secrete interleukin 4, interleukin 5, and interleukin 10. Now, they will ask in the examination, what will interleukin 4 do? It will cause IgE production to increase more. What will interleukin 5 do? It will cause eosinophils to increase more. Eosinophils. Remember these points, please. What will interleukin 10 do? It will decrease the T helper 1 cells. It will increase the T helper 2 cells. Remember, Mohim Jiddan. Okay, I will not repeat again, please. Interleukin 4 will induce IgE. Interleukin 5 will increase eosinophils. Interleukin 2 will increase T helper 2 cells. I hope you understand. Inshallah, we understand more better when we go furthermore. Okay, such that I don't want you to get disturbed because it's very, very important. Okay, I'm not going back. I'm just telling you that the pathophysiology is the bronchial hyperresponsiveness, bronchial inflammation, endobronchial obstruction. Okay, now mamana re-exposure to the allergen, that is the re-exposure to any agent will cause hassasiyah. Now, what will happen is the IgE mediated activation of the mast cells. Okay, the mast cells. Okay, early phase. So the mast cells will cause IgE related reaction. Okay, now inflammation of the major basic protein, we call it MBP, major basic protein, that perpetuates more bronchoconstriction, that is the late phase. So in the early phase, we have the mast cells. IgE will actually activate the mast cells, and the mast cells will help in releasing of the histamine and tarif vasodilatation. It will increase the permeability. That is very, very important. So when the mast cells get activated, what will happen? Number 1, there will be release of the histamine. Number 2, there will be vasodilation. Okay. Number 3, there will be increased vascular permeability. So this is the basic function of mast cells. Now this is being activated by the IgE. I go back. IgE was activated by interleukin 5. MCQ. Eosinophils were activated by interleukin 5. And T helper 2 cells are activated by interleukin 10. Very, very important. Okay, this is the main pathophysiology. I don't want you to confuse more. Okay, we go further more. Okay, what do you mean by type-specific pathophysiology? Especially in an asthma hassasiyya. Another one is asthma ghair hassasiyya. What is the main specific? No, in asthma hassasiyya, I told you IgE. IgE will activate the mast cells and tarif, okay? And the mast cells will do histamine release, vasodilatation, and vascular permeability. IgE type 1 hypersensitivity to a specific allergen. Number 2, characterized by, I told you, mast cell degranulation, releasing al muhim jiddan, antihistamine. If you go to any Saidaliya, what will he give you? He'll give you antihistamine, bidun prescription, antihistamine. Saudi Arabia, maruf jiddan clarinase, or anything, okay, after prior phase of sensitization. Haza type-specific pathophysiology. Number 2, pathophysiology of hassasiyya, of asthma ghair hassasiyya. Now, irritant. Any irritant entering the lung, okay? What will happen? Anything entering the lung, awwal shay is neutrophil release. Then submucosal edema. Then taban, yani airway obstruction. Then the very famous, which comes in the examination, is the aspirin-induced asthma. We call it non-steroidal anti-inflammatory disease, exacerbated respiratory disease characterized by SAMTA triad. Remember this one. Number 1, inhibition of the COX. Okay, I'll try to show you. COX, that is the prostaglandin E2, and which will cause increased leukotrienes and inflammation, then submucosal edema and the airway obstruction. Number 1. Number 2, chronic rhinosinusitis, and in the nasal area you get the polyposis. Very, very important. Number 3, we have asthma symptoms. So this is a very famous and very notorious, which comes in the examination, especially in SMLE. Every time it comes, it's called aspirin-induced asthma. Okay, so the inhibition of cyclooxygenase 1. Okay, it will cause decrease in prostaglandins, increase in leukotrienes, and inflammation, causes submucosal edema and airway obstruction. Remember, cyclooxygenase 1. This is prostaglandin E2. Nowadays, what they are giving is anti-leukotriene treatment. Inshallah, you'll learn this in the 4th year. It's very easy. I don't know tell now because you'll be confused. This is the one. Okay, we go further more. Now, you should be able to know what is this, these particular things. Otherwise, it will be difficult for you to understand. Now, these are the normal, the asthma. Shubhada, Alan, Sahal Jiddan. Mechanism of, what is this called? Mechanism of endobronchial obstructions. Shubhada, endobronchial obstruction. This is the normal smooth muscle, smooth muscle, the mucosa. Okay. Now, endobronchial obstruction and the characteristic clinical presentation of asthma. We heard about the dyspnea, expiratory wheezing, and persistent cough. So I told you in the starting. Caused by what? Bronchospasm. Shufina? Caused by number 1, bronchospasm. Rakam Wahid. Mucosal edema. Shuf. Rakam Ithnain. Ubadan. Increased hypersecretion. Now this will cause more mucus production. Sawalillah. I told you. Other kullu shay. Causing increased mucus production, that is bronchial hypersecretion. Yusamayesh, bronchial hypersecretion. Okay. Now, anybody ask you why there is dyspnea in the asthma? Why there is expiratory wheezing? Why there is persistent cough? Tell them because there is bronchospasm, there is mucosal edema, there is hypersecretion of mucus causing bronchial hypersecretion. هذا هو كله pathophysiology. شوف هنا cross section هذا زي كذا. شوف هذا lumen يعني ضيق هنا مفتوح جدا يعني. Okay. Now this diagram is again very important for you to understand. Now this is the main pathophysiology of asthma. You can see the normal one over here. You can see very good epithelium and also stick, but you can see there is bronchial inflammation. That is, I told you, T helper 2 cells and eosinophils. Okay, I told you very clearly. I'll just go back so that you don't forget it. Now, eosinophils are activated by interleukin 5 and T helper 2 cell by interleukin 10. Interleukin 5 and T helper 2 cell interleukin 10. Remember, okay? Now, increased mucus production, we have seen that. You can see the goblet cells. Shuf, you know, the goblet cells. Shuf, the goblet cell. Hyperplasia. They will be helping in, say, you're getting more mucus, okay? And hypertrophy of the smooth muscle cells. Then you can see the basement membrane thin over here. So, shuf, you know, mucosal edema, thickening of the basement membrane. Shuf, edema. Zaikida. Hina, mafi, zaikida. Then increased blood vessel formation. Sure, the blood vessels formation so much here very small, and basically what is happening, the airway tract has become reduced, okay, lumen becomes reduced. So has a bronchospasm. هذا كل شيء موجود في الأسثما. مهم جدا. Okay, very important to understand. Okay, we go furthermore. Now this is again a very important area to understand. Now this again we are continuing the pathophysiology. Just we want to expand this. This is an early phase, and this is the late phase. Shuf, an early phase, an antigen. Shuf, an antigen here. An antigen coming is taken up by the dendritic cell. Shuf, dendritic cell is antigen presenting cell. Okay, so they take up the taken up by the dendritic cell, cause the release of interleukin. Shuf, hada, they release the interleukin. Shuf, interleukin, okay, cause interleukin from T helper 2 cells. Now T helper 2 cells will release the interleukin. I told you very clearly before. Okay. And starting cascade of intracellular events resulting in what? Mast cell degranulation. Shufina? Eosinophils become activated and mast cells become activated. So mast cells release a variety of chemokines resulting in what? Vasoconstriction, increased vascular permeability. I told you before. Edema and mucus production. Again, I'll tell you. An antigen is taken up by the dendritic cells, causing the release of interleukin, Schuffer diagram, from the T helper cells and starting a cascade of intracellular events, resulting in mast cell chemoattraction and degranulation. Mast cells release a variety of chemokines, that is histamine, everything, okay? And that will cause vasoconstriction, okay? Increased vascular permeability, that is called edema, and lot of mucus production. This is the early phase of asthma. Go to on the right side, the late phase. Shuf, late phase, the prolonged activation of the initial pathophysiological response, that is the early phase, results in cellular destruction. You can see the destruction. Shuf, in epithelium, okay, mawjood. In a destructed epithelium. Shuf, destruction of epithelium, a major basic protein comes up, cationic proteins, more eosinophils, inflammation, bronchoconstriction, mucus production, edema, other late phase. So I hope you understand the pathophysiology. This is the main area to understand. Okay. If there are any questions, do please ask me. No problem. I'm still over here. We go further more. Okay. What is this one? Anybody? Now this is very easy to understand. This is the asthma photograph of a lung tissue. Okay. That is the intermediate magnification. You can see severe bronchial inflammation and obstruction of the lumen. You can see how this lumen is, once again, all this lumen is obstructed, sir, by the mucus. Can you see the mucus juva here? Lazim hawa here, mafi hawa. Show mucus juva. Okay, this is the normal one. But you can see the bronchial over here, terminal bronchial, severe bronchial inflammation, obstruction of the lumen due to accumulation of the mucoid exudate. Kullu exudate juva, exudate. Afahimtum? The epithelial basement membrane shows, you can see the number of goblet cells increase. Shuf, in a goblet cell which produce lot of mucus has a increase in number. Okay, the epithelial basement membrane shows thickening and number of goblet cells has increased drastically. Because why? The mucus is more. See the mucus jua, more and more. This is a typical appearance of the bronchial asthma. Has a pathology jua lung yani. Afahimtum has a histopathology. You can see the normal bronchial over here, but you can easily see over here. It's very easy to understand. Okay, we go further more. Now the diagnostics. Now this is the last thing I have to tell you, because without this we can't understand. Okay. Asthma can be diagnosed in patients more than 5 years of age based on the combination of number one and the Yarifal clinical features of asthma. What were the clinical features? Dyspnea, expiratory wheezing, okay, all such things are present in asthma, and demonstration of reversible bronchial obstruction. Now, what is the diagnostic? Yani you mean كيف يعرف diagnosis of asthma? Number one is the pulmonary function test. Okay, this is very, very important. The second line, if initial pulmonary function test is not conclusive, then you try to provocate the bronchial epithelium by giving some drugs. But after giving the drugs, you see the patient clinically, then you try to do the PFT. Now, PFT is very important. I think the physiology people will teach you. You don't have to worry much about this one. You got to know what is actually happening in that one. Okay, we'll try to see each and everything slowly, such that everything will become more. Now, what do you mean by PFT, pulmonary function testing? Now, what are the characteristic features of now? Now, if you do PFT, inshallah, I will tell you when I take the second class for you. One class is taken by Dr. Ahmad and me, and we are teaching COPD. Okay, Ahmad will teach chronic bronchitis, emphysema, and chronic bronchitis. I'm teaching asthma. Then this is called obstructive lung disease. Okay, I will teach you on 13th restrictive lung disease. Okay, so the PFT findings of obstruction different from the restriction. Okay, now he's telling over here characteristic finding observed using the PFT modalities that described below. So you see a obstructive pattern in asthma. You see in chronic bronchitis. You see in emphysema. You see in bronchiectasis. You summarize airflow limitation as obstructive lung disease. Reversibility of airflow obstruction on bronchodilator administration. For example, Ventolin, okay, salbutamol. The patients in the early phase will become normal. Reversibility of the airflow obstruction in the early phase, but the late phase becomes difficult. Okay, now you should know that this is one of the most important slides for the examination. One of the most important slides for the examination. Remember the slide, okay? What are the key points? There will be air trapping. Suppose I'm Dr. Alaa, I am a patient of asthma. Okay, so what happened? I inspire normally. I take the air normally, but to make it outside, I'm having difficulty. Hada yusama obstructive lung disease. So airway trapping will be there, number one. Okay. Number two, slow flow out. I can blow out, but very slow. Number two. Number three, less air out. So number one, airway trapping. Number two, slow flow out. And the third is less air out. Yani some air will be, some air, lazim jua. Okay, lazim inside. Okay, and less air out. Number one, forced expiratory volume, slow flow rate, slow flow rate, which reduce. So FEV1 is actually reduced. That's all. Okay. Number two, reduce forced vital capacity. Less air out. Slow flow out yani FEV1 reduced. Less air out yani reduced forced vital capacity. Okay, slow flow rate, reduced forced expiratory volume. Okay. Now, if you do an FEV1 by forced vital capacity, all this ratio normally is something different, but in asthma or any COPD will be reduced much. Hada hallmark, hada muhim jiddan Allah, sifat Allah, muhim jiddan lil chronic obstructive lung disease is FEV1 by FVC ratio is very much reduced. This is the main thing we should understand in the obstructive lung disease. Inshallah, I'll try to show you. First of all, I told you airway trapping, airway trapping. So what will happen? Residual and total lung volume. So in obstructive lung disease, chronic obstructive pulmonary disease from air trapping. Shufina, air trapping. Shuf air trapping is there. Okay, both fall in restrictive. So air trapping, like the residual volume of the lung will be more. So residual volume and total lung volume will be more in COPD. And in restrictive lung disease, which I will teach you on 13th of February, the residual volume and the total lung volume will fall. because in restriction, you cannot inhale more. You cannot inspire better. In obstructive lung disease, you can inspire, but expiration difficulty. So less air fills the lung due to restriction. Inshallah, I'll teach you this in the next class. Now, this you got to understand. This is the normal one. You got to know this. Otherwise, it will be difficult for you to understand. Okay. 1 second. I'll try to tell you much with this one. Now, this is basically this is the normal one. You actually see in the normal, but what is happening over here in the acute asthma? This will become concave. This will become concave, and the forced expiratory volume will be decreased over here. You can see normally it's up to like this. It will decrease over here. So forced expiratory volume also will decrease, and we have this one over here, and forced vital capacity will also decrease. Now, it's very, very important to understand this one. Now, to understand this one, I just want to tell you very important area of understanding. Otherwise, we don't try to understand much. Now, expiratory flow is impaired by the narrowed airways. We have seen that the expiratory flow is actually totally collapsed in asthma. Therefore, the peak expiratory flow rate is lower than normal with a slightly concave. You know this concave, the fourth expiratory flow. This is called concavity. Now, this concavity comes in asthma, remember, and it becomes very normal in the normal people. So the expiratory flow is impaired by narrowed airways. Therefore, the peak expiratory flow rate is lower than normal with a slightly concave scooped. We call it scooping. Scooping. This is scooping. This because the forced expiratory flow rate is lower. Okay, so the residual volume is high. That is 2 liters, as the narrow airways have to prevent a full expiration. So that what will happen is the residual volume and the total lung volume will increase in asthma, or it will increase in the COPD also. Now, this is very important. This scooping is due to forced expiratory volume, that is, will be decreased. Very, very important to understand. Okay. We go furthermore. We got to understand many more things to understand better. Okay. Now, I just wanted to ask you something. Now, these are the what do you mean by MEF over here? Just to show you what do you mean by MEF, 75, 50, and 25. MEF is the mean expiratory flow. Okay, mean expiratory flow. That is 75, 50, and 25. You got to know it. What do you mean by PEF? The peak expiratory flow. You can see the peak expiratory flow. Here it is normal, here it is decreased. Decreased. Okay, I told you before. Now, what do you mean by other things I want to tell you also? This is very, very important to understand. Okay, we go furthermore. Now, this one is...
Doctor?
Yeah.
What's the meaning of MEF?
MEF is the mean expiratory flow. The expiratory flow, this is normal for the patient, not the patient, the normal person. It will be like this. But since the pulmonary expiratory flow is decreased in asthma, shuf here a gap, has a gap, decrease. Huh? And when the patient expiratory flow is coming down, he's expiring. Shuf, I'll make a sound. It should be like this. Shuf. When I'm doing an asthma patient, it's understand? This 75%, 50%, 25%, 0. I'll try to make you use over here. Shuf, my expiratory flow, 100%, 75%, normal. But for asthma, it is like the decreasing, 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 decreasing. It should be over here. Now it is over here. It is over here. It starts from here. It's going. Has a Yusamma peak expiratory flow from the, it goes from the 75%, 50%, 25%, here 0. So this will become like that. So this
Doctor,
yeah.
can I ask you? Okay, peak expiratory flow. This is the test, yeah?
Yeah, this is the test of the pulmonary function test, in which the
Also,
forced expiratory volume is also decreased and the forced vital capacity also decreased. Okay. Now I'll tell you ma mana forced vital capacity. Shuf. Al-Muhim Jiddan, I'll tell you. Forced expiratory volume 1. Mana, I'll tell you. Just wait on. Forced expiratory volume 1. Now, expiratory volume in 1 second. Okay, I'll show you. Can I just open my video? You've got to see me. Can you see me now?
Yes, we can.
Okay.
Yes.
Now see my face. I am doing forced expiratory volume in 1 second. Has a 1 second. Okay. Now, mana forced vital capacity. I just inhale. Okay. The amount of air which I want to expire in large number of time has a use of forced vital capacity. Forced expiratory volume 1 in 1 second. Haza, understand? So forced vital capacity is more decreased than the forced vital capacity in asthma. So the ratio, I go back. Shuf, I'll go back now. 1 second. I'll go back. Now you can see this one. Forced vital capacity, slow flow out in 1 second is also reduced, and reduced vital capacity, less air out, forced vital capacity, maybe 5 seconds or 6 seconds, we don't know, 4 seconds, that is also decreased. But FEV1 is more decreased than the forced vital capacity. So this hallmark is the hallmark diagnosis of asthma. Understand, my dear students?
No, doctor. But what about peak expiratory flow? I don't understand.
Yeah, it's very easy. It's very easy. What do you mean by expiration? Al hawa barra, sa?
Okay.
Hawa barra. Shuf, hina, we start doing the expiratory flow here. This is the whole vital capacity, sa? So hada 75, 50, 25, 0. Hada kullu forced vital capacity. Okay. Now in this patient, what will happen? What I will do is I'll one second. This card, I'll do one thing. I'll add a slide for you, and I'll make you understand more better. Okay. This will be more easy for you. Okay. Can you see this? Can you see the screen?
Yes.
Okay. Now I do the forced vital capacity. Okay. Now this way must run 4 seconds. Okay. This is the normal maybe. 75, 50, 25, 0. Hada kullu forced vital. Now this is normal for me. This is normal for me. But in asthma, suppose this is the normal forced vital capacity. Asthma starts over here, decrease, huh? And it will go like this, shove like this. This is called scooping. And the family, 75, 50, 25, 0. So this will be the forced vital capacity will also reduce, but in forced expiratory volume in 1 second, reduced more than forced vital capacity. This is also reduced. So FEV1 over F forced vital capacity is a decrease more. That is, suppose it is 4 liters, it will become 2 liters in asthma. So suppose Dr. Alaa has 4 liter capacity normally, but when Dr. Alaa becomes asthmatic, I expire only 2 liters. Hada hua. Okay, I'll just go back to the diagram such that you understand. Shufina, I start the forced pulmonary expiratory volume, this thing, 75, 50, 25. So you can see the asthma patient, this is decreased, okay? And this is becoming a scoop, scoop. This occurs in asthma. And this is the normal person. Shufina, normal obstruction. I think you understand.
Yes, thank you, doctor.
Yeah, we go further more now. Without wasting our time, I'll go further more. Okay. Now, this question is very important, like asthma, AERD, aspirin induced. This comes in MCQ in your SMLE, USMLE, and Taiwan University. Asthma, chronic rhinosinusitis, nasal polyposis, chronic asthma. If somebody tells me to give an MCQ, I'm going to give in this one. Okay, very important. So asthma induced, aspirin induced asthma. This causes rhinosinusitis symptoms, acute exacerbation by injection of aspirin or Panadol. Okay. Now dysregulation of what? Arachidonic acid. I told you before, metabolism, overproduction of leukotrienes also. Okay. I told you. Nowadays they're giving anti-leukotrienes. And the treatment is monteculas, zafarculas. If you can go to the Saidalia, tell them to give monteculas, they're giving it off. Okay. Another studies for the asthma, allergic workup or the hassasiyah workup considers allergens are suspected to play a significant role in exacerbation, like skin allergy test, skin pricking, just to see the hassasiyah agent, intradermal skin testing, and they want to see eosinophilia ziyada wala la. Okay. أول كان يجي rather than بيضاء مرتفع جدا وبعدين في eosinophils مرتفع جدا. Antibody testing to IgE and allergen specific IgE. كله حق التحليل يعني تحليل حق الأستما. Additional diagnostic test is very important, not routinely done, but for the MCQs in the examination. Sputum البلغم إذا كان سوي تحليل حق البلغم. أنت شفت Kirschman spirals. I'll show you the diagram. World mucus plugs, the sputum formed by the sheds of the bronchial epithelium. Mohim jiddan. Or badan al-Charcot Leyden crystals, histopathological findings in patient with eosinophilic inflammation and proliferation. Come on, show for diagram. Then the Crayola bodies, aggregate of desquamated cells. So you see three pathologies. Number 1, Kirschman spirals. Number 2, Charcot Leyden crystal. Number 3, Crayola bodies in asthma, sputum. Al-Balgam Hangal sputum people. Hada shuf, Kirschman spirals. Wa hada shuf hada, hada Charcot Leyden crystals. They might ask you, Ma mana Kirschman spirals? Kirschman spirals are world mucus plugs in sputum by shedding of the bronchial epithelium. Okay? Ma mana Charcot Leyden crystals? Charcot Leyden crystals are histopathological findings in eosinophilic inflammation and proliferation. This can come in the examination. Okay? Now, I thank you so much. And any questions I'll take up. I hope you understand. It's a very interesting disease and very easy to treat. Very, very easy to treat. Don't worry. I did not teach the treatment for you, but very easy to treat. And it is a reversible disease, mostly reversible. Okay? And any questions? And anytime when you read, go and read. And if you have any doubt, you can just give me a WhatsApp on this number. I have the number, you have people you might be having, or you can take from the leader 0500441013. Okay? Any questions, Sanafri, or from the female side? I hope you understand.
Yes, doctor.
Barakallah fik, barakallah.
Doctor,
Yeah, I will send you the recording. Yeah, what do you want? Do you want something? Hello? Can I close now? Nobody is speaking. Hello, can you hear me?